Today I will talk about one very important topic, that is intestinal ischemia. In your exam, this intestinal ischemia a very tricky point, and sometimes we miss to find out the actual diagnosis. At first I have put an important scenario. At first go through this scenario. SAQ means a short answer question. A 65 years old male presented with sudden onset abdominal pain or lower abdominal pain, whatever it is. He is mildly anemic, pulse 74, okay, irregular, and low volume. Abdominal examination reveals nothing abnormality. No abnormality on abdominal examination, but pulse is 74, irregular, low volume, presenting 65 years male patient with sudden severe lower abdominal pain over the last 3 hours. What is the diagnosis? So at the end of the video, you will find out the actual diagnosis. And before that, we'll go through the theoretical discussion of intestinal ischemia. Intestinal ischemia, that means the ischemia of the intestine. It is sometimes called abdominal angina. Abdominal angina is the angina, that is the pain in the intestine or in the abdomen due to decreased blood flow due to any cause. And this intestinal or abdominal angina is of two types according to the presentation. Number one, the chronic mesenteric ischemia. And number two, acute mesenteric ischemia. So AMI and CMI. AMI means we know acute myocardial infarction, but it also means acute mesenteric ischemia. The cause of intestinal ischemia, whether it is chronic or acute. The headline of the cause of mesenteric ischemia are mainly three, that is arterial occlusion, venous occlusion, and non-occlusion. Arterial occlusion, venous occlusion, and non-occlusion. So at first, the arterial occlusion, that is the mesenteric ischemia due to occlusion of the arterial system, and that might be most importantly, the most important cause of arterial occlusion is the atherosclerotic disease. So the older patient presenting with this type of abdominal pain most likely due to atherosclerotic changes involving the mesenteric vessels. And number two, the thromboembolic disorder. And number three, the abdominal aorta aneurysm or abdominal aorta aneurysm surgery recently done. And the most important, systemic vasculitis. And among the systemic vasculitis, the medium vessel vasculitis, that is the PAN, polyarteritis nodosa, is the most important one. And also the small vessel vasculitis like MPA or GPA are most important. EGPA maybe. These are the small vessel vasculitis. In another video, you will find out the some theoretical discussion among the on this topic, that is the MPA, GPA, and EGPA. Now our topics is arterial occlusion. Number one, the atherosclerotic disease, and number two, thromboembolic manifestation. Among the thromboembolic disorder, the atrial fibrillation is the most important. That is, the patient having atrial fibrillation may present with sudden severe abdominal, vague abdominal, dumb, just low grade, or severe, mainly lower abdominal or central abdominal pain may present with this type. So don't be confused whether it is just acute abdomen or there is a definitive cause behind this acute abdomen. When any patient present to us with acute abdomen, we just go for that local cause, but it might be the cause far away from the abdomen, like atrial fibrillation or recent myocardial infarction with ventricular thrombosis and that embolism of that ventricular thrombosis. Okay. Infective endocarditis, of course, and valvular heart disease. Any valvular heart disease may cause thrombosis and embolism affecting abdominal vessels, mainly mesenteric vessels, small or medium size of vessels. Then recent any cardiac surgery or vascular catheterization. Then abdominal aorta aneurysm, and lastly, already said, the systemic vasculitis, most importantly, PAN. Now, the second one, that is the venous occlusion. Mesenteric ischemia due to venous occlusion, that is the venous thrombosis. And as we know, the venous thrombosis actually are due to hypercoagulable state. And we know from our hematology discussion, what are the main causes of hypercoagulable state or thrombophilia. So try to remember the cause of thrombophilia or hypercoagulable state. The main inherited, number one, inherited and acquired. Okay, inherited and acquired. Among the inherited, 14C, 14S, and antithrombin 3 deficiency, and very rare, but maybe that is the factor 5 Leiden. It is actually and prothrombin mutation. That is genetic mutation. Factor 5 Leiden and prothrombin mutation. Factor 5 Leiden, I would like to mention, it is the gain of function type of mutation. Okay, it is the gain of function type of mutation. And 14C, 14S, and antithrombin deficiency. So this is these are the inherited. Now acquired antiphospholipid antibody syndrome, APS, that is APS. This APS may be primary or secondary. For secondary, we will search for the cause like SLE, rheumatoid arthritis, Vasset disease, and so on. Next, the acquired thrombophilia, like in malignancy. Any malignancy may cause excessive thrombosis. And hematological disorder, most importantly, the PNAs, paroxysmal nocturnal hemoglobinuria. Paroxysmal PNAs may cause any abnormal thrombosis affecting both arterial and venous system, of course. And lastly, the OCP or any drugs, maybe steroid. Okay, so these are the cause for the venous thrombosis. Now, non-occlusive mesenteric ischemia. For non-occlusive mesenteric ischemia, the most important one is severe hypovolemia due to any cause, maybe severe bleeding, sweating, and so on, diarrhea, and shock, mainly hypovolemic or cardiogenic shock, and maybe some drug that are responsible for vasoconstriction. Most importantly, the cocaine. A young person having the illicit drug user, that is the cocaine, may present with severe abdominal pain or severe chest pain. If it is severe chest pain, then it is acute AMI, acute myocardial infarction. And if it is abdominal pain, then it is also acute AMI, that is acute mesenteric infarction. So in both cases, the cocaine may cause chest pain or abdominal pain. In chest, AMI, acute myocardial infarction. In abdomen, AMI, that is acute mesenteric infarction. So M for myocardial, AM for mesenteric. Now, local cause sometimes may cause mesenteric ischemia or infarction, like volvulus, involve the colon, strangulated hernia, spelling is wrong, strangulated hernia. Okay. Now, how does this patient present? Already I said the mode of presentation is two types, and chronic and acute. In chronic form, the presentation is insidious. Recurrent episode of acute, dull, crampy, postprandial, most important one, postprandial pain. Not only epigastric, it may be central abdominal, periumbilical, or lower abdominal. So, if patient presents postprandial pain, that is the pain happening just after taking some foods, So in an older patient, so you should think about this diagnosis. Maybe other diagnosis like peptic ulcer disease, then chronic pancreatitis, or gallbladder disease. But most important is CMI, chronic mesenteric ischemia. Okay. Now, how will you investigate this type of patient? How will you investigate this type of patient? At first, duplex ultrasonographic study of the mesenteric vessel should be done to see the pattern of blood flow. Then CT angiogram, triple phase, involving arterial phase and venous phase. In arterial phase, we will see the atherosclerotic disease of the aorta and visceral vessels. And in venous phase, we will see whether there is any lesion involving the venous system like venous thrombosis. And of course, echo, ECG, and chest X-ray for cardiac evaluation, and screening patient for hypercoagulable state, that is endothermin 3, 14C, 14S panel, AFES panel, CBC, PVF, to find out the cause of thrombophilia or hypercoagulable state. Now, treatment, the most important treatment with which we usually deal. Treatment of CMI, that is the chronic mesenteric ischemia. Number one, the medical management. Okay, medical management of atherosclerosis by exercise, smoking cessation, antiplatelet, and anti-dyslipidemic, that is the statin, usually statin. Okay, and definitive treatment, if it is needed, it may be endovascular or open surgical. The procedure may be angioplasty, stenting, or bypass surgery, whatever it is. Actually, it is the concern of surgical faculty. So these are the mode of management of CMI. Now, the treatment of AMI, management of AMI. Now it is the time to say the diagnosis of our scenario here. 65 years old male, sudden onset abdominal pain for 3 hours, irregular pulse, low volume, irregular pulse, low volume. So it is the diagnosis of AMI, that is acute mesenteric infarction due to atrial fibrillation in a patient age 65 years. So this patient, actually the primary problem is atrial fibrillation, and due to this atrial fibrillation there is thrombosis and embolism involving the mesenteric vessels, causing AMI, acute mesenteric infarction. Okay, so now how will you manage this patient? How will you manage this patient? Here is the management protocol. Management of acute mesenteric infarction or acute mesenteric ischemia, NPO, that is nothing but oral, to ensure the bowel rest. As because if the patient take food orally, that means that this will aggravate the pain due to bowel ischemia. So no food per oral to ensure bowel rest. And resuscitation by supporting treatment with judicious IV fluid. If it is hypovolemic, give the fluid adequately to correct hypovolemia, and to give the fluid to maintain the ongoing demand, demand. And then to give a broad spectrum broad spectrum antibiotics, of course, as because if the mesenteric ischemia, then this mesenteric ischemia will breach the mucosal integrity. So patient are susceptible to have infection, gut origin, mainly gram-negative. So broad spectrum antibiotic should be given. And anticoagulation if it is needed by the underlying cause. In this patient have the atrial fibrillation, so anticoagulation by low molecular weight heparin, or warfarin. Actually, in this patient, if it is valvular, so warfarin, it is the drug of choice for anticoagulation. And finally, the definitive management intervention. This intervention may be endovascular or open surgical. For endovascular procedure, it is maybe thrombolysis, thrombectomy, angioplasty, or stenting, whatever it is. And if needed, surgical, that is the laparotomy, and surgical resection of the non-viable bowels with end-to-end anastomosis. So this is all about this topic, that is the intestinal ischemia. Hope this video will help to you guys. Thank you very much.